Okay, welcome back, everyone. Wasn't much of a lunch, but I hope you enjoyed it anyway. We've got an afternoon, which is going to be extremely interesting for me anyway, with four speakers who will again continue our dialogue on the issues related to end of life decisions, practical issues, etc. Our first speaker this afternoon, if I can find it, is Dr. Joshua To. Yep. And he is, I'm sorry, yep, so he is currently consultant for the New Territories East Cluster. And he's going to talk to us particularly about elderly suicide prevention and also about guardianship and surrogate decision-making processes. Dr. To, please.
Thank you very much for the kind introduction. I'm Dr. Cho, and in this part of the presentation, I'm going to give a brief overview on our research on the medical legal infrastructures that are in place to protect the human rights of people with decision-making disabilities, DMDs, like persons with dementia, by way of guardianship laws or other forms of proxy decision-making mechanisms. Our main focus is on Hong Kong, but we would also contrast a little bit with the system in mainland China, Japan, Thailand, and Australia. And this work is part of the International Psychogeriatric Association Capacity Task Force, and is the product of collaborations with an array of researchers in the Asia-Pacific region. Firstly, setting the scene, the global population aging is accelerating at an unprecedented pace, most prominently in the Asia-Pacific region. So providing care for people with DMD that is respectful of their human rights is a key challenge for the dense and rapidly aging population in this part of the world. So this is a figure of the world population density. We can see that Asia is of the most highest dense population region in the world. And added to that is that population aging is fastest in Asia and most prominently in China, including Hong Kong. These are the regions that we would briefly examine today. So for these medical legal mechanisms to take place, we understand that they are primarily influenced by the existing legal structure, like whether the region is following common law or civil law or other legislations, the health system, the cultural practices, the mechanisms for reforms, and others. So most of the part in Asia follows civil law. Exception is Hong Kong, and in the Asia-Pacific region, Australia also follows common law. So firstly, Hong Kong. So we are very familiar with the system in Hong Kong. We follow the English common law, while the legal system of the mainland is that of the civil codified law. The main piece of legislature taking care of people with DMD is the Mental Health Ordinance, or the MHO. It addresses the care and supervisions of mentally incapacitated persons, which are commonly called MIPs. It concerns their properties, the treatment, guardianship, and consent for medical and dental treatment. But then some of you may know that MIP is actually a very, very confusing term because MIP just in the law, it just means an adult with a mental disorder or mental handicap. So let's say if the person has depression, he or she is already an MIP. And the MIP do not always lack the mental capacity to decide on matters pertaining to their own medical treatment, welfare arrangement, or financial depositions. Capacity is actually a dynamic interplay between the person's abilities and the demands of the decision task. So when we approach and assess the patient's mental capacity, we always remember that it's decision-specific, time-specific, and domain-specific, depending on the gravity of the consequence of the decision, the complexity of the decision, and capacity may also vary between domains. A person may be able to make medical treatment decisions, but not financial ones. For surrogate decisions in medical practices, the common law basic principle is that non-consensual touching is trespassing. Exception is that, firstly, if the person is an incompetent patient with no proxy consent in law, or if there is an emergency situation, or if there is a doctrine of necessity. One thing that's special to Hong Kong is that the next of kin has no legal right either to consent or refuse on behalf of the MIP concerned. This more or less summarizes surrogate decisions in medical practice. I won't go into details, but for an adult MIP needing treatment, we would assess his or her mental capacity according to the principles we have just outlined. If he or she refuses treatment, even it could be detrimental to his or her own health, but if he or she possesses the necessary mental capacity, we will still respect the MIP's refusal. On the other hand, if he or she is incapable, we will see whether it's urgent treatment or non-urgent treatment. If it's urgent treatment to save his life, we will proceed to the treatment without consent. For non-urgent treatment, but then there is a doctrine of necessity. You have to act in time to prevent a significant decline in the health of that person. We will consider two scenarios. The first one is the one with a guardian. We will seek the guardian's opinion on that, and he or she would decide on behalf of the MIP. But most of the cases, there are no guardian in place, and the doctors, mainly the senior doctors, has to decide it on behalf of the MIP according to the doctrine of necessity and the patient's best interest. And if he or she, the doctors agree, and they can give treatment without consent, and this is according to the Part 2C, after the Part 4C of the Mental Health Ordinance. So for guardianship board in Hong Kong, it's the first of its kind in Asia, and the effect of guardianship order, including requiring the MIP to reside at a specified place, to attend treatment, to receive a small sum for the maintenance or benefit, and to give consent to treatment. The number of hearings is increasing year by year. And there are also emergency guardianship orders in place to prevent elderly abuse, especially financial abuse. For finances, we all know that enduring power of attorney is in place in Hong Kong. It's actually it's a way to protect the autonomy of the person, so he or she can decide on the person who is going to help him making decision on financial choices when he or she loses the capacity. However, it's very uncommonly enacted in Hong Kong. Partially, it's because of the hurdles and lack of education. in Hong Kong, it is required both the endorsement of the solicitor and the doctor for the EPA to be signed so that it is legally effective. And it used to be, the requirement used to be that the solicitor and doctors must be present together at the time and EPA is signed. About 3 years ago, there is a reform allowing a time gap between these two visits because it's really too difficult. However, the take-up rate of the EPA is still very low. We expect there may be some landscape changes with initiative like reverse mortgage, in which EPA is an integral part of the process, and the uptake rate of EPA might be higher. For advanced directive, I think we have quite a lot of discussion this morning, and I'm not going to give too much details on it. In Hong Kong, there is an absence of specific legislation, but it is in place in Taiwan and Singapore. And for the advanced directive, there's in Hong Kong, most of the patients are taken care by the public hospital, 90% of them. And there's a recent improvement in the system that alerts the doctor that the patient has an advanced directive. Whenever the patient's account is opened, there will be an alert jumping out to signify that the person has an AD in place and the doctor is needed to respect the will of the patient. So the challenges and future developments. In Hong Kong, the EPA is still, the uptake rate is still very low. And in Hong Kong, there is no medical legal structure to enable enduring guardianship. It's only when the patient loses his or her mental capacity, then one can appoint a guardian. But how about if the person is still having the mental capacity, can he or she choose who would take care of his day-to-day living, the consent issues? For this part, it seems that we are still lacking behind. The Law Reform Commission has proposed that the EPA may be amended to extend its scope to take care of the medical and day-to-day living of the DMD concerned. But it was rejected by most of the professional organizations in Hong Kong because of the fear of a very powerful attorney to control all aspects of the life of the incapacitated persons. In China, very briefly, medical decisions and medical treatments, they are governed by the tort liability laws. Just like in Hong Kong, there's a presumption of capacity, and one should seek patient's consent. But if patient's consent seems to be absent, the doctor could consult proxy written consent from a hierarchy of close relatives, like the spouse, parents, and children. This is different from Hong Kong. For finances, it's a duty of the guardian to take care of the financial assets of the persons under guardianship. This is quite unlike Hong Kong, and there is no legal concept of enduring power of attorney in mainland China. AD in China is still in a very primitive stage. Although a person may drop an AD when he is mentally fit, the relatives could override it upon the execution, and there are no law to support the legitimacy of such a document. In Japan, they follow a civil law system, but interestingly, there is no law for surrogate decisions in medical practices in Japan. For patients with DMDs to consent to treatment, physicians conventionally obtain consent from family members, but actually this is unlawful. And for patients without families, physicians tend to avoid invasive treatment. And guardians are not allowed to make any surrogate healthcare decisions. For the guardianship in Japan, it's mainly taking care of the assets and the supervision of the daily life of the mentally incapacitated person in question. Is less, although the name is the same, is quite different in content from that in Hong Kong. And there is a provision of enduring guardianship that is somewhat resembling the EPA in Hong Kong. Advance directive, there is no AD laws in Japan, and same like Hong Kong, the system is still in a very primitive stage. In Thailand, also a common law region, also presumption of capacity. If the patient are noted to be incapable or otherwise insane, they have a next of kin hierarchical system to decide on behalf of the patient, just like mainland China. And on the other hand, there is no guardianship law. Culturally, the older persons would expect the children of himself or herself to take care of these matters. And for people in Thailand, they think guardianship law is not necessary for elderly, but it's only for the minors. They have no EPA legal concept. For advance directive, the hospitalized person who want to refuse treatment could submit a proposal to the hospital committee for considerations. However, this is still very debatable in Thailand. About Australia, much of the system in Hong Kong is actually modeled after Australia. We both followed a common law system used in England and Wales. However, one point that's different is that they adopt a hierarchy of persons to give consent for major treatment, unlike Hong Kong. And this list is roughly the same, just like the other regions that we have covered. For guardianship application, these are made to tribunals. And plenary orders are readily made in contrast to Hong Kong. Usually they have a guardian for, let's say, accommodation and guardian for healthcare and the other one for consent and service provision. This is out of a wish to protect the DMD person with a overly powerful guardian. Finance is always another method. A guardian cannot control the finance of the person, and EPA is in place. And unlike the case in Hong Kong, there is no mandate medical certification of the donor's soundness of mind, and EPA take-up rate is much higher than in Hong Kong. They have enduring guardianship so that protection of the autonomy of the DMD is more viable in Australia. So finally, this is a table to compare the medical legal arrangements to protect incapable persons. This is the legal system. Just like to highlight about the treatment when during non-emergency scenario and for persons with guardian. In Hong Kong is consent by guardian, in Australia consent by guardian. But for non-emergency situation and for persons without a guardian, in Hong Kong especially is following Part 4C of the Mental Health Ordinance, and the non-guardian or next of kin have no legal stance. These are further summaries, and if you are interested, this table was actually just published in the June issue of the International Psychogeriatrics, so you can have a deeper look if you are interested. So with population aging, there is an imperative to modernize the medical legal structure to protect the human rights of the DMDs. Some emerging process and gaps in the region. for example, surrogate medical decision, it seems that there is a need for further formalization and consensus building, especially in Japan, mainland China, and Thailand. For advanced planning in Hong Kong, we may need to catch up concerning EPA and possibly consider a mechanism that can render enduring guardianship possible. It's hoped that international dialogues can lead to more reforms in the region. And this is the paper that I've mentioned. You can take a look for if you're interested, and you can contact me for the details. So just a little bit of advertisement. By the end of the year, the Hong Kong Psychogeriatric Association would hold a capacity conference. We will have two keynote speakers. One is Professor Stanford Finkel from the US and Professor Kamal Pesai from Australia. They will update you with the latest controversy concerning mental capacity in their respective jurisdictions. So thank you very much for your kind attention.
Thank you, Dr. Cho, for that very succinct comparison of what's happening around the region. Let's move on to our next speaker. Dr. Amy Chow is a close friend and a colleague here at Hong Kong U. She particularly focuses on family members at end-of-life patients as secondary patients. So let me reread this. Family members of end-of-life patients as secondary patients. So reminding us that there are more people involved that is affected by end-of-life issues. Amy, please.
Yeah, I'm facing some problem.
Okay.
It said the file is in end of life. It cannot be opened. Yeah. So I need some help. Maybe I have to find my surrogate decision makers.
Well, if Amy...
Yeah. I had been... Oh, no, sorry.
Yeah, do we...
Yeah, do mine too.
Okay. Okay. Someone did something. Me, probably. Okay.
Did you euthanize it?
Okay. Thank you. In that case, let's give Amy a little bit of time. Fortunately, her office is not too far from here. May I then invite Dr. Elsie Hui to talk to us about innovations in end-of-life care. Dr. Hui is, graduated from Imperial College. She's trained in geriatric medicine. She's consultant and COS at Sha Tin Hospital and cluster coordinator of Community Geriatric Assessment Team. So she's the right person to, again, challenge about restraints and all the other issues we briefly touched upon this morning. Dr. Hui, please.
Okay. Hello. Can you hear me? Goldie. Hello. Hello.
You prefer?
Yeah. I think we're okay.
Yeah.
So, thank you, and you caught me by surprise. I was going to have a nap, but anyway, thank you so much. It's a great honor to be here in the Faculty of Law. I must admit, a little bit nervous speaking among experts and people from other fields. I certainly learned a lot today. So anyway, today I'm just going to share with you what we've been doing in the Sha Tin area. James, Luke, and myself are quite passionate about end-of-life care in Hong Kong. So are a lot of geriatricians, actually. So forgive the sort of lightweight nature of my presentation style, okay? We have a lot of cartoons and not very many words. So doctors are quite different from lawyers. But anyway, I think this cartoon still illustrates that the same principles, the ethical principles, that we want to give patient the right care for the right patient at the right time and in the right place. So this morning we highlighted that for many patients, we're giving the wrong care at the wrong place and so on. So we, as geriatricians, we are proud that we do emphasize on being person-centered. It's important to be proactive, so you need to anticipate which kind of patients are high risk or who have entered the end of life. And then you've got to provide them with timely and coordinated care. And to achieve this, we usually work in teams across different disciplines, like doctors often work very closely with allied health and social workers. And we try to step across sectors, because if you only look at your own hospital, everything is going to fall apart. So we do reach out to the people in institutions and in the community. And continuity of care is very, very important. You heard the stories that, family are very upset because they are transit from different places, like from home to hospital and back home again, and they get handled by different people who know nothing about the elderly. So I think continuity is really one of the very key factors in delivering good care. And of course, we want to promote the well-being and quality of life in all our patients and allow them to age in their own place. So my talk's going to be divided into several sections. First, some definitions and trends. Basically, how does one identify patients who have reached the end of life? And there's a very sensible way. It's the surprise question that's been well tested by the gold standards framework. Basically, we talk to our own staff, usually healthcare professionals. We say, looking at this patient, would you be surprised if they were dead in, say, the next 6 months or 12 months? And it's a really very, very accurate predictor, at least among healthcare professionals, because we see so many patients and day in, day out, so we know which ones have reached the end of life. And the general indicators of decline, such as having whether they need further active treatment or not. And in some conditions, like for example in renal failure, it's easier because when your blood test has reached a certain figure, then you know you've entered the sort of end of life phase. So I think somebody showed this this morning, but I think I will explain it again. This morning, one of the speakers said there are around 40,000 deaths a year in Hong Kong, and out of these, 8,000 are residential care home elderly who live in institutions. So a fifth, right? So that is very significant, lots of them. And in their last year of life, the consumption of healthcare goes up exponentially. The hospital authority data shows that really, in the last 6 months of life, I think somebody showed this morning, so they spend about almost a month in hospital. But this is like going in and out, maybe 3-4 times before they finally die. Now, why do we target residential care, that population? Because really, everybody wants to live at home, and it's when you are so weak or frail that your family or you yourself can't cope that you enter an institution. So by default, these people would be the frailest, and it's just pragmatic, really, to target them. So around 7% of older people in Hong Kong are institutionalized. This is quite high compared with Western countries. My understanding is only maybe around 2% in the US or Europe. As I mentioned, 8,000 deaths occur in just the medical wards alone at the public hospitals. These residents particularly have an even higher utilization of hospital beds, and the unplanned readmission rate is also double of other elderly people. So let's look at the literature. And everybody acknowledges that end-of-life care is very important. And other speakers have spoken about how to promote a better dying experience. And palliative care is a very well-established discipline aimed at relieving pain and suffering and provide psychosocial support. But traditionally, palliative care physicians looked after patients with cancer or those who were reaching the terminal phase of cancer. In recent years, we're more and more recognizing that patients with end organ failure or advanced dementia have the same issues and are in great need of the palliative approach. But there's only a handful of palliative care physicians in Hong Kong. So I think the approach is much more important. They really need to educate all healthcare professionals who might come in contact with patients who reach the end of life. So yeah, we said it's important for the patient to have some say where to die and where to be cared for. And it is possible to provide quality care in nursing home. Dr. Luk presented his model. This paper was published in the New England Journal of Medicine. And basically, these authors, they're based in Harvard University. And they looked at advanced dementia. And some people may not recognize that dementia is terminal. It's a terminal condition. They just think it's associated with old age. But when patients have reached the last stage of dementia, we classify into 7. When you reach stage 7, the patients only have about 1 more year to live. And they commonly will come in and out of hospital with the same old problem: pneumonia, febrile episode means fever. And usually the fever is related to pneumonia or related to some kind of infection, like the urinary tract infection. And also they will have eating problems that we mentioned this morning. And frequently they're subjected to lots of investigations like blood tests, CT scan, and the doctors would give them intravenous treatment such as antibiotics for their fever. And when they're not eating well, maybe they have a tube inserted. They find that the number of interventions are inversely related. That means if the knowledge of the carer about the prognosis, so if the family or carer are not aware the patient has the end of life, that will predict the patient to have more investigation. Is that clear? Obviously, if there's no AD and no advanced care planning, then the doctors will go ahead and do all is necessary. Okay, so it's a huge burden on the healthcare system, and I'm fascinated that it's being replicated all over the world, and yet not much is being done to change the picture. So going to local studies, actually, our team at Prince of Wales and CU Hong Kong have worked very closely with our colleagues at Queen Mary and Hong Kong U. So together we've done quite a few studies. Back in 2011, we interviewed a group of cognitively sound elderly who lived in residential care homes, and many of them expressed a wish to die in their own homes or in the care home setting. Another study, again, replicated that the majority of residents and also their family prefer the death to occur in the home, if possible. But as we mentioned about the coroner and so on, it is not really possible at the moment. A more recent study, again, found that the 35% of patients prefer to receive end-of-life care in their own residential care home, And some residents say, well, if my home is better, so not all homes are of a high standard, but they say if I lived in a better residential care home, then I would also like to receive end-of-life care there. And they said we would like to have, have staff who have a better attitude. That means being kinder, being more aware of their, their issues. And we also asked, well, how much are you willing to pay? And unfortunately, the elderly are not willing to pay that much. So $400-something a month, I don't think you can get too much from that. But now, in the hospital setting, Professor Wu, she's left, but we started looking at end-of-life care back in around 2008, and we published some papers. This study looked at 80 non-cancer patients, and we look at what kind of symptoms that they have compared with, say, patients who have cancer. And the symptoms are quite generic, but nevertheless, like having leg weakness, fatigue just means you're very tired, with no energy, edema, swallowing problems come up again, and pain. Half of them have pain. So the pain is not like cancer pain, but I think it reflects quite a degree of discomfort. And the carers are very stressed, so they have a high stress index score. And the healthcare professional also felt, they had a sort of slightly lower quality of life indices. And interestingly, we highlighted that the healthcare professional had quite a bit of anxiety about caring for the people who are dying. I think multiple reasons. One, it kind of reminds us of our own mortality, and we're not sure if we're doing the right thing. Are we doing too much or too little? And it's quite difficult to communicate with the family. We're worried that we're saying the wrong thing, and with the family have different expectations and so on. So you really need to give training to the healthcare professionals. And at that time, we already recommended that you need training and care pathways and so on. We looked further at, because of what we found in the previous paper, we conducted a continuous quality improvement initiative, a CQI initiative, targeting end-of-life care for patients who didn't have cancer, who had, say, end organ failure or dementia. And we found that they had a longer trajectory and more symptoms than cancer patients. However, they had less access to palliative care, and possibly just limited to the last few days of life. As I mentioned in the earlier slides, it is the last 6 months or last 12 months of life where the patients are in and out of hospital and not getting better. So although palliative care is very, very good and it's very nice for them to choose where they die, I think it's equally important, if not more important, to address the whole trajectory that maybe lasts up to a year. Okay. So the initiative was carried out in our hospital. Sha Tin Hospital is a convalescent hospital that's affiliated with the Prince of Wales. So Prince of Wales is a big hospital with an A&E department. And the patients would get sent to us after a few days. So the senior clinicians, some of them are sitting here, we agreed that it is important to improve the end-of-life care. So we started a program aimed at educating and training our staff, and we also produced some information pamphlets for the patients and their family, mainly targeting on explaining what is a DNR order, and common problems like tube feeding and bereavement and funeral arrangement and so on. And we implemented a new pathway. I explained it a little bit further in the rest of my talk. But basically, rather than from before all this happened, you just see masses of old people coming into the hospital, and you feel you're not doing something for them. We're hoping to create a new pathway where we can target the patients and then offer them better quality care. So In case you don't know the local setting, although our government promotes aging in place, and we want everybody to live at home and defer institutionalization, and for those who are already in the institution to stay in the same facility, it doesn't quite always work that way. So this was in the news last week, and it's really very sad. I mean, we talked about it among our own colleagues, and we said, how can this happen? There are about 700 OH homes in Hong Kong with housing about 70,000 older people. And unique to Hong Kong, I think we know that we do not have a very well-developed primary care system like you have in the UK, where each citizen has their own doctor or own clinic. So old people kind of rely quite heavily on the public healthcare system. If they're not feeling well, they might go to a clinic, or if they're feeling really unwell, they'll come to the casualty department. All the long-term care is provided by specialist clinics. And since 1994, the Hospital Authority has established the CGAT, the Community Outreach Team. We go out to all these residential care homes and provide care, medical care for the residents. And as discussed, death in residential care homes are not common practice, and all cases would be reportable to the coroner. Rather, the vast majority of patients are sent to hospital to die. Advanced directives and advanced care planning is still quite a new concept, and I think we already know all the negative consequences of deaths. It is very stressful for not only the immediate family, but for other residents of these homes and for family members of other residents to see the police turn up, or you hear about the deceased undergoing an autopsy and so on. So the revolving door, this means that every time a resident has a medical crisis, say if they got a fever, if they look unwell, they get sent to the A&E department. And because when the A&E doctor looks at them, they're so frail, they will always admit them to the ward, because you can't tell. A lot of them can't even communicate. So they get sent to the acute ward, and then they get a whole batch of treatment, okay, including quite aggressive, say if the breathing is not too good, they might put them on a ventilator. If they're not eating, they insert a nasogastric tube. And some of them, because the pressure on acute wards is so great, they can only stay about 5 days. But of course, they're not better, so they get sent to convalescent hospitals, like my hospital. And they continue a kind of, not recovery, but they continue the treatment until they're fit to be discharged back. And this happens all the time, this revolving door. I mean, we often hear that we send patients back to homes, and they get sent back to the A&E the same evening. Okay. So this happens a few times, and then finally the patient dies. And really, this is a very poor quality death. So now I'm going to move on to sharing some of our local experiences. Our EOL program was really born out of a very pragmatic approach. So we knew that there's lots of these people, and we knew that we're not really giving them a good service. Back in 2010, we audited all the admissions from old people's homes, and despite the CGAT, the outreach team, making efforts to channel these patients away from the acute hospital, only 1 in 10 could be admitted. The reason being, our hospitals are so crowded, and there's lots of patients from the acute hospital needing to be transferred to the convalescent hospital. There's this issue about equity, all right? Why would you let these OH home residents jump the queue, all right? And there's so many people, say in Prince of Wales, waiting to come over. Well, that was the argument anyway. we rolled out a new program back in 2012. And the objective was to protect the dignity, comfort, and rights of patients in the last part of their life, and to reduce suffering arising from long waiting time in the A&E department, or the burdensome treatment I mentioned, the crowded medical wards that are not, the family can't even stand by the bedside, and they certainly won't allow all the family to come in to the medical wards. And also the frequent transitions between different hospitals and back to the OH home. And this part I wrote for my administrators because this is attractive to them if I say I can save money. Anyway, same criteria. We targeted OH homes because it's just more pragmatic, because we know a lot of the patients live there, and advanced dementia and organ failure and so on. And those who have a record of repeated hospitalization. And there are several components to the program. We set up a designated end-of-life ward, which is nurse-led. I know today we don't have a lot of healthcare professionals, but I want to highlight what's so special about this nurse-led ward. Well, doctors, if you don't restrain them, doctors are prone to give lots of treatment and so on. We discussed that already. But nurses are much better. They're much more sensible. So they focus on the patient's needs, and they want to provide care and comfort and so on. So we allowed nurses to lead this ward. They provide continuity of care because we try to readmit patients into the same ward. So as soon as the patient comes in, they say, oh, I recognize you, and these are your preferences, and your family is like this. You have how many daughters and sons. We are certainly restraint-free, okay? I'm very proud to say that my hospital is restraint-free. It can be done. We promote fewer feeding tubes, and we promote careful oral feeding. Often the family come in and help us to feed the patient. We have flexible visiting hours, and when patients are really dying, we allow them to go into side rooms. So a lot of training was provided both to the ward nurses, the CGAT staff, and also very importantly, the staff of the OH homes. And we had to work with different stakeholders, such as the A&E department and the medical department of Prince of Wales, the fire department because of the ambulances. So you've got to persuade the ambulance staff to convey this rather ill-looking elderly. We have to convince them and say, look, don't worry, there's a bed waiting at Charlton Hospital. Please try to convey them. But sometimes they say, oh, we're not comfortable, so they still send them to the A&E department. Okay. And then we brought in the concept of advanced care planning. So in geriatric patients, what are the issues? Most commonly, we will mention CPR, ventilation, artificial fluids, artificial nutrition, antibiotics, and other treatment. But I think these really account for over 90% of the scenario, the so-called decision that patients or family have to make along with the doctor. Okay, so we usually it's not just the patients, but generally among Chinese families, the family are involved as well, and so we discuss the prognosis, and then we identify the goals and offer them treatment, offer them options. And this is quite interesting because the family would say, I didn't realize I had a choice. I thought the doctors, prescribed something, that's it. So they were really impressed. Okay, provide options. And through that, we are offering dignity. Okay, so this diagram just illustrates how we coordinate the care. Patients in the residential care home, instead of going to the A&E department, we try our best to admit them directly into a convalescent hospital. However, if they do turn up at the A&E, at least the A&E knows about the advanced care plan and try to honor that, and likewise in the acute medical ward. But really, we try to sort of round up all our patients into the convalescent hospital. The CGAT is very, very important because we're trying to change the behavior of the residential care home staff. So we say, well, if your resident is not looking very well, instead of calling 999, please consider calling the CGAT nurse, and she'll try her best to help you. Either the CGAT doctor can prescribe some treatment, or if we agree the patient needs admission, we will send them to a designated place. And of course, we always review what we're doing, any slip-ups and so on, and through that, everyone is learning and trying to do better. And as James mentioned this morning, some hospitals are able to offer farewell rooms. Even in the A&E department in Queen Mary Hospital, they have farewell rooms. I'm afraid in Prince of Wales, they can't do it at the moment. But certainly in Sharting Hospital, we can allow patients to go into a side room when we know they're in their last day or so. And we allow flexible visiting hours and lots of psycho-spiritual support for the family through our social workers and other volunteers, and also the palliative care team. So this diagram just shows, again, the patient journey. So in the old days, patients would come into the A&E and then get admitted to acute ward, and then come over to us and go round and round and round until they die. And now we try to improve support in the elderly homes. If they can stay there, that would be perfect. However, we acknowledge that because of the frail condition of the patient, they do need admission from time to time, so they can come in directly, jump the queue, but I think they deserve it, okay? And because of the ACP in place, we're able to eliminate all the burdensome treatment. The patients, we focus on comfort care, so we do have some outcomes. In the first year, you don't have to worry about this. Just look at these two columns, success and failure. What we call success, if the patient can end up in the designated ward. Failure is doing the old thing, okay? So back in 2012, it was 3 to 7. So still, most of the patients we consider fail. But this past winter, we were able to change the ratio 7 to 3. So 70% of patients could be successfully bypassed. And this is without any extra resources. It's really by changing the system and persuading all the stakeholders to change. We also surveyed the users. Not many patients are able to do the questionnaire, but the vast majority of the family liked our program. They felt they were involved in the decision-making of the ACP, and they were given lots of support in the OH home. And everybody liked the direct clinical admission to our hospital. And they acknowledged that patient suffering was reduced, and they were overall, I think they were satisfied with our program. And you may be surprised, but we get a lot of appreciation letters from patients who died, right? So they're not always unhappy, despite the outcome of a death. And our own nurses also really enjoy this process because they felt they're really adopting a holistic approach, and by promoting autonomy and empowerment, both to the family, patients, and also themselves. You remember I mentioned there was a nurse-led ward. So they had increased job satisfaction, so even though they were very, very busy, they felt better. So in summary, over a period of 3 years, we were able to reverse the ratio of patients coming into our hospitals and bypassing 70% of end-of-life patients from the acute setting. The ACP compliance was really good because we have a great computerized electronic health record in HA. So we just put it on the alert. Anybody who checks in the patient will see the ACP. And satisfaction was very good, but there are always limitations because CGAT doesn't work 24 hours. And sometimes the patient is too ill, so the ambulance staff will insist to send them to the A&E. But I think we still need to have more input into the ACP and the training of staff, both in hospital and other settings. And from this autumn, the hospital authority will launch a corporate program, a little bit similar to our program, the one I described. So I think I'm very pleased to see that finally it's not just a sporadic pockets of good practice, but finally, hopefully, it will all be rolled out all over Hong Kong. And we wrote this up, it's quite a simple paper. I think if you're interested, I am happy to email to you. So I want to acknowledge all the staff involved in delivering this quality program. And also there are other very, very good models of care in Hong Kong. For example, Donghua Sam Yun, they have a program in Tai Po where they provide a lot of psychosocial support, and they also work very closely with the local hospital. And Salvation Army have the sort of a die-in-home program where they focus on the last 72 hours of life. So in summary, what we would like to see is that, as I mentioned, there are lots of good practices, but they still sort of sporadic. It's really important to roll out everything at scale and pace. But there's a great need for more education and debate, and I think this is a great setting. I believe the legal profession can help us, and also the government and policymakers should act urgently. Training is always very important. And in our healthcare system, it's important to adopt these practices. So linking up the primary care, the outreach, OH homes, A&E, and hospitals. And these documents, obviously, will facilitate the care. And finally, there are some new homes with a dual license. So they have a CNA license and a nursing home license. So I think the government is paving the way for death to occur more commonly in OH homes. But I think the coroner ordinance still needs to be, yeah. So that's what I want to share today. Thank you.
Thank you so much, Dr. Hui. Our technical bug hopefully resolved. But it actually, in its own way, is great because now this leads us finally to one group that we've not discussed yet so far today, and that's the family and how issues that we have brought up impacts them. In fact, there was a question and comment earlier this morning about what it means to family when things like that happen and they are affected by it. So once Amy's ready, yes.
So sorry for all the. I am from social work department, so I'm really honored to have an opportunity to share this with you. I'm ignorant of legal part, but I have been in touch with a lot of patients, families, so I hope that I can outline the psychosocial context of those who are receiving end-of-life care, and then you can use your expertise and see how it can interact well. As everyone said, lawyers are very concerned about the terms, so I start off with definitions. The term end of life is very confusing because for the US and from the Europe group, they had very different definition. Some of them define end of life at the very final days of care. But in general terms, we prefer to use it as the time when they have the diagnosis of a terminal illness. So how they define end-of-life care? Actually, it is not restricted to cancer. Any form of chronic life-threatening illness can be the reason why you can receive end-of-life care. And recently, according to the top 10 cause of death, dementia and diabetes are also on the list. So you can imagine some illness, you may think that it is not that life-threatening, but in reality, it can be one of the cause of death. Now, from this definition, you can also see that it is not only restricted to the medical side. They want to be sensitive to the personal, cultural, and the spiritual values. So it makes the situation very complicated with all this kind of individualized care. And they also share that support for the families and friends are also part of the end-of-life care objective. I like the Taiwanese definition in highlighting end-of-life. They use a term called 5 whole, which include the whole person, the whole journey, the whole family, the whole team, the interdisciplinary team. And this is a newly added one. They used to have 4, but now they add the 5. They hope that the whole community is involved in provision of the end-of-life care. And in end-of-life care, they define family is the unit of care. I think the picture is more powerful than words. So this is a very powerful picture by Robert Pope. He is a patient. He had been spending a lot of time in the hospital. I think when you look at this picture, you can see that it is not only the patient, but the family members are suffer. As you can see, maybe it is just 4 a.m. in the morning. The family members spend equal time in the hospital. They don't know whether they should wait for a bad news or whether they want to have a good news, their family members recover. But you can see that it is very exhausting and emotionally torture. Now, sometimes family member is not only waiting at the hospital, they need to carry out practical tasks. You can imagine how you can drive at the same time worrying about the deterioration of health of your loved one. And you can see this face. I think he is the father. You can see how difficult to manage both tasks at a time, to drive safely, but at the same time want the son to be okay. Now, this picture I love very much because I see a lot of this kind of picture at the hospital. Now you can see that when someone is nearly die, all the family stood have a very stiff position, hoping to be strong enough to face the situation. But when they have a chance, when they had a chance to escape from that atmosphere, you can see they collapse, they are very upset. But when they go back to the room, they will become a very strong person. So the patient, the families are actually suffering a lot. Chinese like to use food to express our concern and care. But you can see from this picture, Westerners also do so. We want to feed the person, we want to show our love. But as you all know, end-of-life patient, most of the time they don't have appetite. The more they eat, maybe they feel even much worse. So how to struggle between the care and the concern? But we can understand that as a family members, we can do nothing. So the best way is to just build on some food or whatever. You can see that the mother is in Chinese like this. Whenever you want to show your love, you cook a big meal for your kids, you boil the soup for your husband in order to make him coming back home. So all are about food, yeah. So some scholar actually said that family members is a secondary patient because most of the time when the doctors see the patient, they also see the family members. And most of the time, the doctors and the nurses actually also offer support and care for the patient, for the family members. So they call them a secondary patient. Now, maybe you can take a look at some of our data. We collect the clinical data mining data from the medical social work department. And you may be a little bit surprised to see that when we check the stress of patients and family members, actually the stress of a patient is much higher than patient most of the time. The anxiety, agitation, the family member is a little bit lower. Maybe they have to hold up their emotions to make sure they can perform their will. Depressed mood, I do think maybe they have, but they don't express it well. They have the social pain. Patient want to commit suicide, but maybe the family members also have some form of this kind of wish. These are the psychosocial distress as well. So what they need is, they need the information, they also want some practical assistance, they want some emotional coping assistance, and most of the time, they want some support in communications. This is a clinical data mining by Dr. Jie and a group of doctors for palliative care. They also do the clinical data mining and found that patients in the final 6 months of life actually spend only very limited time. The total days of hospitalization is about 19.7 and 32 in the non-palliative ward. Now, adding with the palliative ward, you can see that in the last 6 months, they spend about 40-something days, which means 75% of the time at the last 6 months of their life are spent at home or maybe the residential elderly institute. But most of our patients, they are still staying in the communities. They are still staying at home. Now you can imagine, if you have a dying patient at home, how much stress will the family members is bearing? Now the stress is not only about taking care at home. They need to arrange different clinic visits. Now, even though they have a regular clinic visit, they have multiple speciality. Like maybe Monday, they need to go back to the palliative ward, and the next day, maybe they have a cardiac appointment. And the other day, they may need to go to see an occupational therapist and physiotherapist. So the family members actually are bearing a lot of burden in facing all this kind of arrangement. And more critically is the alternative medicine. I don't know why. All the so-called special doctors or the special miracle doctors, the herbal practitioner, they usually live in the new territories. So if you have to take the dying patient to see the doctor, they travel a long way, they spend a lot of time. Actually, the transportation is a big issue. And sometimes they will have to got a new medical investigation, and they also struggle whether to send the patient to the A&E, whether they call the ambulance, as Dr. Hui just mentioned. The quality of life of family members are also affected. You can imagine if you have to have a patient at home, how will that affect your sleep? When you just listen to some noise, you will be waken up, you will go to check whether the patient is okay. So their sleep issues are also disturbed. The meals are also disturbed because they need to feed or they need to arrange very special diet for the patient. And most of the time, they don't have a time to take their own meals, or maybe they are forced to take the very clean meal, like only eat vegetables, no chicken, no beef, no other kind of meats. So their diet are also affected. Psychologically, they are facing a lot of stress. Most of the time, they would say this word: time is not on our side. So whatever I can do, I would try my best to do it immediately. And then, if they are offered chance to make a choice, like the medical decision, they will be struggle whether this is a good choice or not. They will be ruminating about whether I have made a right choice or not. So they also have that kind of struggle. They hope that to reduce the future regrets, but they also have to learn there are loss of control, because the patient will eventually have a deterioration, and no matter what kind of knowledge, no matter what kind of resources you have, the results are the same. the patient will die soon. They will face a lot of helplessness. Now, but sometimes when the patient are sent to the hospital, and then the hospital said, now we are undergoing through a pandemic period, no visitation. Now, they are sent back home. This is a time for them to have a rest, good sleep, because the patient is in good hand. But then, when they are sleeping well, they will be guilty of being so relieved. Now, I also have a question about the decision making. Now, this is a very old studies by Richard Fielding from the medical faculty, but I try to find a more updated one. They don't have anyone. But I want to think about. I want to highlight this point is, at that time, 21 years ago, in Hong Kong, some of our patients actually do not have a clear understanding of what they are suffering from. So the diagnostic disclosure is about 70% only. Now, I think nowadays it is much higher, but still there should be a number of patients who may be ignorant about their own diagnosis. Now, if they are ignorant about their own diagnosis and prognosis, how are we going to start off our conversation about advanced care planning and all the decision making? And even though we don't have the statistics now, but I still hear about the doctors telling me that family member pushing the doctor not to tell the diagnosis to the patient, in particular for those who are old, who are quite fragile, or maybe have a heart problem. They will try to persuade the doctors not to disclose the diagnosis. Again, if they don't have this kind of information, how can we move on with the advanced care planning? Now, but in reality, we also found that some elderly or some patient, they prefer not to know any information about their diagnosis and prognosis. I think these statistics may be quite stable till nowadays. So if this is not made by a patient, then the whole decision-making process will be fallen onto the shoulders of the family. Now, but when we have to make the decision, I found that in families, a lot of time, they can't put up this kind of conversation in their normal communication. The word death, the word terminal illness, most of the time are excluded from their conversation. And on the other hand, because they don't communicate, they will try to guess what is in the other's mind. And they may say that maybe my brothers do not want me to make the decision, or maybe my brothers want me to do this or not that. So they are guessing everyone's decisions. Now, I think Chinese also have a lot of complicated family dynamics, in particular talking about how to define filial piety. Offering more that for the patient, is that good? Or should we respect the way that a patient wants to? But sometimes filial piety is not defined by your own parents. It is defined by your distant relative. They like to comment on your performance by saying that you are doing so and you are doing this and this, you are not a filial person. Now, another question I have been facing with a lot of families, who should be the one who make the decision for the patient? Sometimes we respect the Chinese culture, the elders should be the one. Now, but in most cases in Hong Kong situation, the elders usually do not receive much education because they are the one who support the family, they join the workforce very early. Usually the youngest is the most educated. So in these dynamics, who is going to make this decision? And also, with the more emphasis on the son, sometimes a daughter who spent a lot of time taking care of the patient, she knew what exactly the patient wants. But in reality, in Hong Kong, maybe they respect the men more than the women. So the daughter do not have a voice, but they have to follow the son to make the decision. The spouse, the elderly, will that be another person who can make the choice? Now, just we heard from Dr. Cho, actually all the family members do not have the right. The doctors should be the one to have the final say. But most of the time, the Hong Kong doctors are very nice. They will try to consult the family members. So again, this will put back the burden to the family members. And we also see that in Hong Kong, a lot of us had to pay back the mortgage, so we have to work. So if you have to work, if you have to be a caregiver, that kind of stress can be torn very seriously on the persons. But spiritually, they also have some struggles. This is a very common classical question, which we usually do not have answer. Why bad things happen to good people? Why him or her? Why not me? But also why me? And if they have some religious belief, sometimes it is a testing time. They will have a test of their faith. They also have a great sense of powerless. Now, what are the challenges we are facing, both as the family, as a citizen? I think many speakers talk about the aging population, so this is one of the issues. Now, but on the other hand, we are now accepting other form of diagnosis as the recipient of the end-of-life care. So in the past, over 80% of patients are oncology patients. But if we have other illness, including the heart, the lung, or the other form, or the respiratory issues, then the illness trajectory will be very different. Now, just now, I also learned from Dr. Hui that 93% of our patients die at the hospital. Now, but these studies who try to capture the world scene, the highest one is Japan. They only have 69. So you can imagine, with the expansion of our patient pool, with the growing population of our elderly, I do think that 93% of care at the hospital at the end of life will not be visible for our future generation. So we must expand our work on the arranging the care in the residential age home or even at home. So the different illness also impose a different trajectory. So you can imagine in those old days, the trajectory is quite clear for cancer patient. You had quite a stable period of time, and at the very final stage, you will have a sudden deterioration, and it is so predictable, and you will be ready for the care. But now there are growing number of frailty patients, which means their functioning are low all along. So it demands a great level of physical and psychological care for the patient. Now, there are also some demographic challenges that I would like to highlight. Now, the household size in Hong Kong in 1981 is 4, but in 2011 it turned to 2.9. You can imagine we are having more couples with no child, and then all the children likely are moving out, they have their own places. So the household size is smaller and smaller. So the family members is not actually it's not family members, it's only a family member. Because if we drop to 2, that means one is patient, one is the family member. So who is going to care, how to care? As I said earlier, the number of children we have is dropping. So you can imagine our next generation, we only have someone to take care of us, but we have only one child. The good thing is we have no more family dynamics between the siblings. But the bad thing is we will have the sole burden on one person. Now, internationally, they are trying to address these issues. You can see that in Europe, they are talking about building the community palliative care, in particular around in the community. They had a paper, they had set up some tools for us as reference. In 2014, just last year, the WHA, which is the World Health Assembly, which is the legal the organization of WHO, they are asking all the countries to try to strengthen their palliative care. And they are asking all the government to develop a national strategy in end-of-life care. So what are some of the possible local strategy? This is something in my mind and we really hope to share. First of all, I do think that family members do wish to take care of their family, of the dying patient, but they don't know the skills, they are insecure, they are incompetent. So how we can empower the family and also maybe the neighbors to support caregiving of the dying patient can be one direction. And on the other hand, we need the community service to build up their competence as well. They have the staff more ready to take care of the dying patient. Now, say for example, now we have some home care service. They will deliver meals and they can have some personal care for the elderly. But sometimes they find it very difficult to support dying patient. They are afraid whether if I move this dying patient, will I hurt them? Will I be able to do this? So how to strengthen the community care worker to work on it is important. We also have to change the societal, cultural values. Sometimes they think someone died at your next door is not good for you. But if we can accept this is something natural. In those old days in China, everyone died at their home. Now even in Taiwan, if you are dying, they actually try to rush back home to make sure your spirit will be able to get back to the original place. So how we can change the culture and make our society more acceptable for someone to die at their own place is important. And I think Dr. Hui also talked about letting the patient die at long-term care service, letting the patient die at home. But again, I would like to do a promotion because I'm one of the board members of the Society for Promotion of Hospice Care. We have an innovative project. I think by the end of this year, it will be open. It is called the Hong Kong Jockey Club Hospice Home. We had unit for the dying patient and the family members to move in. So they don't need to worry about dying at their own place and contaminating their environment. But at that place, it is a place for the whole family. So they can cook together, they can spend time together. So we really hope that the family can stay together at the final days. At the same time, I would like to share one idea which I learned from a French colleagues. The government actually have some caregiving leave, the mandatory caregiving leave. Is if you have a family members who are dying, you can apply a formal leave. You can have a few weeks staying at home with your salary paid so that you can care for your family members. But they also have a very innovative caring act. Is if you have some unclaimed leave, you can donate it to a pool. And then this is a pool for caregiving. So in case if another colleagues who only have very limited annual leave, they can draw from the pool this leave, and then they can take care of their family members with the salary still able to be paid to them. So I think that will promote a very caring society. And after all, a lot of us had a lot of unpaid leave which is forfeited. So why don't we use it in such a way? Lastly, in order to have a cultural change in the society, I do think that life and death education can help. So we hope that with more discussion of advanced care, with more understanding on life and death issues, we can have a more detailed discussion of the advanced care planning and reduce the fear of death. Now, Hong Kong had been placed in the middle of research called the Quality of Health in 2010. I don't think our end-of-life service is poor, but what makes ourselves not so good is we are not having a standardized national strategy. But I think it is not easy, but still, government participation in this movement is important. Now, I am also working closely with the Singapore team, and they have been drafting a national strategy for palliative care, and they will be using it, I think, at the end of this year as well. So I hope that we can also think about, as a government or as a group, whether we can set up some national strategy, and that will show our commitment to care for both the patients and the family. So thank you for your listening.
Thank you very much, Amy. Just a quick remark. Not everyone likes soup at home. My wife boils soups. I find reasons not to go home. Our next speaker, and in a sense, very appropriate speaker, is Marie. Marie is a colleague at the Center for Medical Ethics and Law. She's a lawyer by training, and prior to joining the center, she worked in healthcare or the healthcare industry in a international law firm. Marie is going to tie up the relationships between legal and clinical environments, and perhaps tell us what are some of the things we should or should not be doing. Marie.
Thank you. I really don't want to use this thing, but I'd rather stand up. All right, well, I feel a little bit bad to bring us back to the somewhat contentious or controversial issue of physical restraint after we've had such a nice discussion of families and caring. But unfortunately, I guess it does sort of close the day in a nice loop. As Philip mentioned, I was a practicing attorney in the US, and I came from a regulatory and transactional background, so I was often working with hospital clients. And this got me interested in sort of issues of quality and safety, which is what led me actually to the topic of restraint, because it is actually a very significant quality and safety issue. So in this particular talk, I'm just going to talk about nursing homes. The entire universe of hospitals and everywhere that physical and chemical restraint is used is a bit broad, so we're just going to talk about nursing homes. And really, I'm going to use it as a tool to think of it as almost a case study, to look at how the legal and clinical environment interact and how regulation influences clinical factors. So just a quick roadmap, I'll just give some background, talk about some of the reasons why physical and chemical restraint is such a persistent problem and the scope of the problem. Talk about how we can measure and understand quality. Talk about how I'm going to think about regulation in this presentation, because I'm going to take a very sort of specific law and economics approach. I'm not a law and econ person, so if there are law and econ people in the room, I apologize if I mangle anything. And then I'm just going to compare and contrast Hong Kong and the US, and I know there are also some people here who are experts on the use of restraint in Hong Kong, so I'm probably going to mostly focus on the US. And then think about whether, if we approach regulation in this way, does this really offer us any insights that can help us address this problem, or at least understand why it does persist so much, and why we have so much variability in the use of the rates of use of physical and chemical restraint across countries and within countries, and how physical and chemical restraint might actually be related to each other. So as you can see on the slide, in Hong Kong, for example, we have a relatively high rate of physical restraint paired with comparatively low or moderate rate of chemical restraint. And in the US, we have a low and dropping rate of physical restraint compared with quite high and possibly increasing rates of chemical restraint. And I'll talk about that a little bit more further. Before I get into it any deeper, though, I do want to just give a very big caveat that exact rates of restraint are really difficult to measure. There's a lot of debate in the literature. There's a lot of debate just among people and scientists about this, academics about this. It's not only because it's difficult to get accurate responses from surveys and various ways of measuring this, but the actual way in which you decide what counts as restraint varies between the various studies. So some people are going to include bed rails, some people are not. Some people are going to get really creative about how they're restraining a patient. Maybe they're going to push the wheelchair up against the wall so the patient can't move. Do you count something like that? So depending on how you look at it, rates could be really high or less high. In terms of thinking about how they're related, if you really wanted to do it, I think actually it would probably require some mathematical modeling, which I am not up to the task of, but there are some people doing really interesting work on that. So that's just a little bit of background. In terms of the as you already know, it's a very common practice in long-term residential care facilities, frail geriatric patients nearing the end of life, especially those who are demented. It's basically a standard treatment to have either physical or chemical restraint. This is a persistent problem, as people have said repeatedly today. We've been talking about this for 20 years. I personally haven't, but I'm sure other people have been having this conversation for 20 years or more, which is a little disturbing because we know quite well that restraint use is associated with adverse clinical and psychosocial outcomes. It's actually used as a negative indicator of quality of care. So it's a little crazy that we're just going ahead and doing something that we actually use to measure negative quality of care. And there's quite an extensive body of evidence linking use of restraint, especially physical restraint, with harm to patients. Actual injuries, when people struggle against the restraints, and even at just a more basic level, you have the obvious problem of deconditioning, like Joseph's example of a lady who suffered from a stroke. She's lost the use of one arm, you're going to restrain the other arm. How's she supposed to do physical therapy? You've basically given up on this person. You've said, okay, you're not going to be able to move again. And that's not really how we should be thinking about people from a rehabilitation point of view. And of course, then you have the obvious psychological impacts. This is very, even for patients who have lost most of their cognitive capacity, this is very distressing. For patients who have somewhat more capacity, I think all of us can put ourselves in the person's place and imagine what this would feel like. And of course, the family members. This is obviously a difficult experience, even for family members who do consent to the use of restraint. Why do people use restraint? Nobody wakes up in the morning and thinks, wow, I'm such a terrible person, I'm going to go tie up my patients, I really get a kick out of this. Nurses are wonderful people doing a great job. They're doing their best to keep patients safe, to help patients. Doctors also go to work to help patients. Everyone is trying to keep patients safe, to reduce falls and accidents, to provide the absolute best care that they possibly can. The issue is that it's essentially a persistent misconception that restraint use can help prevent falls. There's not really significant evidence for this in the literature. So there's that issue. There's also sort of a persistent question about whether, if there's not significant staff, by using restraints, it allows nurses to have more time on the wards to take care of other patients. So there's some back and forth on that, or whether higher staffing levels can address this issue. But the first one to address is really falls. And there's been some work that shows that actually it's more likely that you'll have an injury if somebody is restrained because they're trying to get up and they're tied down. And so they're more likely to struggle. So, okay, we have this background, we have this problem, it persists forever. There's tons of legislation trying to address it all around the world. Particularly in the US, it's been targeted heavily as something that needs to be reduced, but also in the UK and even in Hong Kong, there are guidelines that restraint should be only when absolutely necessary. It should be essentially a physician should order it, and it should have consent of the person if they have capacity or a family member. So it's really only supposed to be in minimal situations, but obviously if you look at the numbers, that's not what's happening in reality. In terms of academic studies that have tried to look at this, they've really focused on education, particularly for nurses, and again on staffing levels. If we just look at some numbers for prevalence, like I said, the numbers tend to vary depending on what studies you look at. In the US, it's dropped quite a bit, and again, I'll talk about that more later when I talk about regulation, but we've got it down to almost 5%, which is starting to get near the range where you'd actually get into the recommended range of what would be appropriate for people who are actually having a fit of some kind and might actually injure themselves. The recommended range is about 0 to 5%. On the other hand, if you look at chemical restraint, that's about 34% in long-term facilities in the United States. They are trying to reduce that as well, but it's quite high right now. Hong Kong, on the other hand, and Joseph had some interesting numbers about that, and I know that people are working on trying to figure that out right now, exactly what the rates are in Hong Kong. But I think probably in terms of what's been published, a low-end estimate is at least 20%. So it's pretty high. I think that's a low estimate for Hong Kong. And then chemical, probably 11%. Again, probably a moderate estimate. And so, like I said, it's hard to define, but you could say, are you going to count vests, belt restraints, wrist ties as the obvious ones? But then there's also ones like a lap tray that's not allowed to be put up, wheelchairs that are wheeled into a corner, the use of actual seclusion or physical space to restrain a person. Chemical restraint, just briefly, if you're not familiar with it, it's generally off-label prescription of antipsychotic medications. These were initially thought to be safer when they first came out, but of course, once more studies were done, it became clear that they were associated with a number of adverse effects, including diabetes is the most significant one. The clinical guidelines for these is it's really not appropriate to be prescribing these unless there's a diagnosed disorder, symptoms of psychosis, or severe persistent symptoms of dementia that would lead to aggressive behavior. But of course, they're prescribed heavily, particularly in North America. And the evidence of benefit is pretty limited. There's actually, because of the adverse effects, the risk of death is significant enough that they now have a black box warning from the FDA. So then this brings us to the issue of quality. So I think I've given you enough background that you can understand why restraint use is such a big issue when we talk about quality of care in nursing homes. And there are a number of issues that we can talk about as care practices employed by nursing homes. And we use these to measure quality: physical restraint, urinary catheters, feeding nasogastric tubes, antipsychotic use. And each of these are practices that can affect the health, physical and mental health of residents. They also have quality of life implications. And these generally have some clinical justification, arguably, but they're widely recognized as also having adverse effects. And so we can use them as quality indicators. And generally, if you find that a large proportion of the nursing home residents are subjected to these, that's going to indicate that there's a quality concern. Staffing is the other sort of major element that we look at when we're thinking about quality. When you think about what happens when there's a quality problem, then we have deficiencies or citations, or various ways of talking about this. And generally, when you have a facility with a lower staffing level, they're more likely to get a deficiency. This is pretty obvious. But what isn't quite as obvious is that the staffing mix matters a lot. So it's not just add more people, essentially throw money at the problem, and you've fixed it. It really matters what type of staff you're adding, how they're trained, how frequently they're turning over, and how the organization and management are functioning. So we have this variation that I mentioned in restraint use, not just between Hong Kong and the US, but other countries like Canada and Finland are quite high on both physical and chemical restraint, whereas other countries such as Switzerland are comparatively low. And a variety of studies have indicated that it's not really adequately explained by either the organizational characteristics of the nursing homes or the case characteristics of the patients. So you have to look at a mix of other factors: attitudes and beliefs of the staff, philosophies of care, and I would say probably also the regulatory context, which is what I'm really interested in. In the terms of how the regulatory context influences the clinical environment, as I mentioned, you can have citations for deficiencies, but there's also issues like that you wouldn't necessarily think of as a regulatory issue, but availability of medications, the license status of the providers who are able to be available at the facility, what types of procedures require a physician order, the accreditation status of the facility, what types of penalties or fines happen when there are a deficiency, improvements that the facility might make in anticipation of inspection, or a decline in quality post-survey by inspectors. So these are actually all regulatory, if you think about it, even though it might not at first seem to you that these are legal or regulatory issues. And does this give us an opportunity to use regulation as a solution to any of these? I think when you look at the literature, I've read a number of articles that sort of in the last paragraph say more regulation is needed as a solution. And so what I was interested in asking is, well, how would you do that exactly? How would you do that in a country like the US, which has definitely thrown regulation at the problem as a solution? And how would you do that somewhere like Hong Kong, where we have a quite different situation and where there's comparatively little regulation? What I'm particularly interested in, and I've read quite a bit about in the US context, is the issue of essentially regulatory offsetting. So when you have regulatory pressure to improve quality of care in one area, for example, fall reduction or reduction of physical restraint, you might see offsetting behavior. For example, increased use of antipsychotic drugs or forms of restraint that are not enumerated such that you would receive a deficiency for them. So how do you support quality, patient-centered care when you have this multi-dimensional aspect to the problem? So is regulation really your solution here? And when we relate this regulatory influence to the clinical environment, we take this law and economics approach. Just very quickly, we use regulation to achieve objectives by setting incentives. And when we have a highly regulated setting like healthcare, we do minimum quality standards. We can enforce these in a number of ways: financial penalties, loss of accreditation or license. And generally, we would expect quality to improve when a minimum quality standard is directly related to the dimension of quality. So unfortunately, quality is multidimensional. There's many areas, many aspects of quality. So if you very specifically and stringently apply regulations, you can get this offsetting behavior which is counter to your goal. So essentially, regulating intensively in one dimension of quality may improve it in that particular area, but have the opposite effect in other dimensions that are under less regulatory scrutiny. So that's very confusing, and hopefully these examples will clarify it. So, first of all, even when the standards are directly related to the quality, you would generally expect improvement in this situation. You can still get an unexpected result. So, for example, in 2011, Grabowski et al., they found higher minimum direct care staffing standards. You would get a decrease in inappropriate antipsychotic medications. Okay, great. But increased use of physical restraints. Okay, not great. What went wrong? Because higher staffing reduced the relative cost of physical restraints compared to the use of pharmaceuticals. So we now have enough people that we can afford to go around and tie everybody down, and it's cheaper than drugging them. So this is not the result that you're going for, right? So this is an unexpected result. Normally, the thing that you're targeting, the standard that's directly related to quality, would normally improve. But you can still get this perverse result when you do something like this. What's more standard is a negative result that occurs in a dimension of quality that's not directly related. So, for example, an improved standard for fall reduction results in increased use of physical restraint. So you say, okay, we're going to issue 10 citations for falls. Okay, great, we'll go around and tie everybody up, which is exactly what Bobliss et al. Found in 2012. So you do find that nursing homes change their use of care practices in response to regulation, but not necessarily the way that you would want them to. I mean, it's not all bad. Generally, of course, the usual thing is that you do improve these targeted standard that you're aiming for, but you can get these perverse results, and particularly when there's a lot of targets that you're trying to aim for, and you're hitting them with these very specific standards, you get this kind of phenomenon. So let's think about Hong Kong, and I am not going to go into a lot of depth in Hong Kong because I am sure that there are people here who know a lot more about it than I do. But we do have this relatively high prevalence of physical restraint, even though we have technically guidelines saying that it should be limited. Why might this be? Local factors that might influence this. Nursing culture is the obvious one. But even more so, there might be family and staff preferences for tube feeding, gets mentioned a lot. There may be also issues with the design of the wards in hospitals and in nursing homes. There's not a lot of private space, so there's a strong pressure on the staff to make sure that residents are not wandering around or causing disturbances, for example. Need for modernization. In how many cases, for example, do you think that they have video monitoring equipment or alarms available to them to keep track of a resident who might be prone to wander? That in a more modern facility, you might be able to just say, okay, well, we're just going to let that person have a little more freedom. Lack of education and awareness regarding potential negative outcomes with restraint use. There have been studies on this, but I think at this point, we've all been talking about it for a pretty long time. So at a certain point, I do wonder if I added lack of political will this morning after the first round of talks, because you do have to wonder if that might be an issue. But rates of chemical restraint remain pretty moderate. And this is where I wonder if the regulatory climate could be influential. The Hong Kong system is not incentivized the way the US system is. Nursing homes or residential care homes for the elderly there's a mix of public and private residential care here, with different classes of residential care facilities with different levels of medical service. Because of this, there's a difference in the US, it's very much tied to payment. And so here you don't really have that financial incentive to respond to regulatory pressure. I did look at the guidelines, for example, the Code of Practice for Private Hospitals, and I was actually taken aback to note that in, for example, the Code of Practice for Private Hospitals, nursing homes and maternity homes, there's a direct reference to restraint use being meant for fall prevention in the guidelines, which is a little bit behind the times. But they are supposed to have consent from the patient or family members, frequent check. It's supposed to be done with consultation with the physician. And certain other guidelines for other facilities are even more detailed. We may also find that emphasis on fall reduction for nurses and previous negative experiences with patient falls may lead to unwillingness to take risks or to have what might be considered an unsafe environment. So there's been a lot of studies on how nurses make decisions and what type of atmosphere or culture in an institution allows nurses to feel more comfortable making ethical decisions. So that's one issue as well. When we think about why there might be lower levels of chemical restraint, I had a chance to talk to Dr. Kwok about this today because this was sort of a private theory of mine. But I thought it was probably because we just don't have the staff on hand who are capable of prescribing in most cases. And he said that he thought that that was pretty much the issue as well, that in most cases there's not a psychiatrist who's on staff able to prescribe antipsychotic medications. Instead, they're just visiting relatively infrequently. We get the geriatric assessment teams coming through relatively infrequently, versus, for example, a US nursing home, which is going to have a medical director on staff and is likely to have doctors who are actually on staff with prescription capabilities. So it's I think that might actually explain quite a lot of the variation. So bringing us to the US, it's an extremely complex regulatory system. It all kind of comes back to OBRA 87, which was the legislation that essentially addressed the incredibly bad situation of nursing homes in the US, established rights for elderly people in nursing homes, and cracked down on use of restraints. Federal guidelines have to be implemented by the states. Nursing homes are annually certified for participation in Medicare and Medicaid. And this is what gives us this sort of big stick that the government is able to use to enforce the regulation, because if they don't get their certification, they don't get their money. That's a big deal. Having practiced in this area, people take these citations very seriously. All of these businesses pay very close attention to who's getting cited for what. This supports entire legal practices doing this kind of work, just keeping track of who's getting cited, who had their license pulled, and when they're going to get it back, that type of work. And there's millions and millions of dollars at stake. So when you compare that to something like Hong Kong, it's almost no wonder that you don't see the same kind of complex system with the same kind of intense pressure happening, because there's just nowhere near the same kind of money involved. So there's just some more details about the US. The result, of course, is that we have increasingly low rates of physical restraint, but increasingly high rates of chemical restraint. One other thing that this might be related to, of course, is that we have Medicare payments for prescription drugs and a very active pharmaceutical industry. And I think that is also something I would love to talk to people about here in Hong Kong. I've been spending some time trying to figure out who pays for elderly people's drugs, how much they pay, and who's making money off of it. So if anyone would like to talk to me about it afterwards, I would love to hear more about it. Because I was trying to follow the money in terms of that, and was rather unsuccessful in terms of tracing it in hospital authority materials. In terms of other examples and sort of where this might be going, there's an increased regulatory focus on chemical restraint because it is growing. I think there's increased understanding of the dangers of polypharmacy because we now have computer systems that are capable of tracking medication. There's been a move to really improve those and keep track of all the different medications that elderly people are on. I know that there's an effort to improve the pharmacy systems in Hong Kong. So I think that's a real opportunity for change and improvement. And I think in both the US and Hong Kong, people are really starting to become aware of this issue. I'm very curious about the countries that have very high rates of both forms of restraint. So I think that's one of my next projects, is try to figure out what on earth is going on with their medical culture and legislation that would result, like Canada and Finland have incredibly high rates of both. So that brings us to how can we use this information to try to have better support for how caregivers can make good decisions. When using physical restraint, it's a practical, and chemical restraint, it's a practical decision, it's an ethical decision, it's a workplace decision. So it's something that's difficult on many fronts. We have a lot of material showing that education, cultural change, teaching caregivers to value patient autonomy, to see restraint as a human rights issue is really important. But I think we also have to look at the healthcare system. We have to consider quality of life of the patient, place the patient within the context of his or her larger life when we think about goals of care. Safety, patient safety. What does it mean to be comfortable for the patient? What does it mean to have convenience when we're delivering care? When somebody is nearing the end of life, all of these things that are reasons that we might, for example, restrain someone, change. I think the meaning changes when somebody's really nearing the end of life. And this is something that Joseph brought up. When somebody is really very demented at the very end of life, it doesn't make sense to be feeding them through a nasogastric tube and restraining them. And I think when something like that happens, the system has kind of lost sight of the person within it. And that's a quality of care issue as well as an ethical issue. We have to realistically enable providers to work this way. I think I lost my mic, sorry. And it really reminds me of working as an attorney. We dealt with the Joint Commission a lot, and they've dealt a lot with medical error reporting. And when you have a punitive culture in an organization, it's been their experience that it really discourages reporting of medical errors. So they've spent a lot of time focusing on ways to encourage people to simply report medical errors so that people aren't afraid of losing their jobs, afraid of making ethical decisions. You have to really change the organizational culture. And I think the pressure on staff, for example, to absolutely eliminate falls. I think this is really a difficult issue when it comes to physical restraint. I think while we're really focusing on fall elimination, I don't think we'll ever see complete elimination of physical restraint. Although, Elsie, I'd love to hear more about your experience at your hospital. And then, of course, we have to consider how, for example, polypharmacy is related to falls. So this interrelationship between all the different forms of restraint and all the exact quality problems that we're so worried about. There are plenty of interventions that we can try instead, and we can also think about what we're doing in care that may lead to other decisions further down the line that we don't want to make. For example, putting in an NG tube. And I think we have to have a different view of the elderly and what the lives of the elderly should be. I think we have to have a view of them that includes movement, that includes a life where they're able to get around and do things, feed themselves. If we think of the elderly as people who lie in bed and die, then of course we're going to end up not facilitating their opportunities to do anything else. So we have to proactively plan for movement and activity as part of the culture of care. And that means workplace culture, physical design, and regulation all have to interact and all affect medical care. So looking forward, although I think this is a great start today, collaboration between academics, clinicians, patient advocates, and that's one area I was hoping we should have invited more patient advocates, and policymakers in this area remains relatively limited. There's certainly scope for further dialogue, and it's really important because both clinical quality improvement and ethical treatment of patients, we're all people, we're all going to die, we're all going to get old, I hope, and we all have human rights and dignity, and we have to have a deeper critical engagement with something like this. We can't just let it be a routine thing that just happens. So that's all. Thank you.
Well, we've had 4 very interesting talks, and it would be wrong if I don't allow you some questions. I promise you there's still coffee afterwards, but perhaps a few questions from the floor. Anyone? Everyone's tired. Yes.
Thank you. I'm Dr. Gavin Chan, a pathologist in charge of Queen Mary Hospital mortuary. I have a comment or questions to Amy. Amy, thank you for bringing up a very important concept that family members are the secondary patients. If they are patients, then we as a doctor should take care of them. And so far, I think HA do not have any clinic for them. In fact, I know in the mortuaries of other countries, there is what we call a next of kin clinic. Next of kin clinic are those clinics, especially for those family members who have lost their loved one. And although in overseas, these next of kin clinics are mainly information giving, but I think there are, of course, more we can do, like psychosocial support to them. Do you have any comments on this? Or do you aware any next of kin clinic in your experience?
Actually, I also have a question similar to that.
Dr. Chan.
Yeah, because I personally experienced kind of second patient because of my father. You know, at that time, the whole family is in very stress, and the doctor, we are trying to help in such a way that to find the best doctor to cure my dad. But I was told by the doctor that, curing my dad is just psychologically curing your whole family. It's not, in fact, curing my dad. Because, you know, we are trying putting him in more painful treatment like chemotherapy, whatever. You know, but at that situation, you know, no one take the initiative to help our family. So I was in a nightmare for about a month, even after my dad's death. I think your concept is very good, holistic. But even personally in Hong Kong, I experienced that even, I think just like at the end the speaker, quality speaks louder than quantity. Besides the manpower issue, the number should increase. I think the mindset or whatever, how to nurture the caretaker in such a way that they have a missionary mind and also have a vision to and how to nurture them, or educate them in such a way that they have this concept to help the secondary patients to implement this whole holistic concept. But in Hong Kong, I personally experienced that just like Lam Zhang Yu or whatever, the government, they have policy, but they have no vision and no missionary. They just say, 頭痛醫頭，腳痛醫腳。
Don't worry.
Yeah.
I think we have a few good doctors here. I know them personally, like Dr. Lam Botin, and this morning we have James Lok, and all these doctors are very nice, and they treat the whole family as the unit of care. But just a brief response to Dr. Chan. In Australia, in the mortuary, they also have a counselor, which is specially designed for the psychosocial care. But one thing that I'm thinking is if we can strengthen the medical social workers' role in their practice, I do think the medical social workers can also take up part of the duties to take care of the psychosocial need of this group of secondary patients. But I also have to say, Dr. Gavin Chan's team is also very good. The staff at the mortuary actually also take good care of the family members. So I think if we have the heart, we will be delivering the quality service, no matter what background or what discipline we are from. And it is more like a human work. And I see a lot of angels here. They are working on this direction.
Okay, any other questions, comments? No, everyone's tired. Yes.
Spiritual dimension. I was trained in the U.S., and many countries come to the U.S. to learn about spiritual care or pastoral care in the healthcare settings here. In Hong Kong, I don't know how many people or how many of you know about the practice of spiritual care here in Hong Kong. One thing I would like to ask the health authority to consider is to make it a paid service within the hospital to hire chaplains to provide care for, this will be really the holistic care for the whole hospital. Being a chaplain in the States, we are very, very heavily involved in patient care. The chaplains are professionals in the healthcare setting in the U.S. We have theology, well, we provide theology and psychology. So in some areas, we're overlapped with social work. But I guess the premises is whatever the institution can provide, we need to provide. There are a lot of services that we can work together to do that. So I just want to make an advocacy for the use of pastoral care or spiritual care. Actually, Chinese are very spiritual, and we don't impose our spiritual values on patients. And also, we support family members, and we support the staff. We support the community. I like to describe chaplains as like a trump card.
Okay.
Things that staff cannot fix, they will go to the chaplain. And the chaplain, I guess we are more trusted individuals, and we can get a lot of information or history about the patient and the family. And we work well, and we were trained. We work well with all the disciplines. So I just want to make an advocacy for that. Yeah.
I think from my limited experience, some hospitals where there is a stronger sort of religious base in terms of its background does have that, but it's a bit more variable. But yeah, I take fully what you're saying, the involvement, and it wasn't really sort of an omission on our part. I think we're building up to involving more and more disciplines to come in and talk about these issues. Again, thank you. Yeah, Nicholas.
If I understood this lady correctly, or if I heard her correctly, more to the point. Sorry, if I heard the lady correctly, I'm turned on. She was talking about spirituality. Can I go back to the example this morning of my former colleague?
Yeah.
And he died in Queen Mary Hospital. He decided to, or his family agreed with his pre-indication that he would leave his body to be dissected by the medical students, and his body's just been released to his widow. Oh, sorry, not his body's been released, but his ashes have been released. And one of the things that upset me was the funeral, in inverted commas, which was a self-arranged thing, took place in a room that was adjunct to the mortuary at Queen Mary. Mm. It was from the section where the coffins are normally taken out to the hearse and so on. It was bare flags or bare tiles. There was no spirituality, no religious sense, no solemnity at all about that room. Now, this was a man who had given his body to benefit of medical science, who died in the hospital, where the mortuary staff could not even be bothered, and it distressed his grandson greatly to get his jaw to shut. So he was there with his mouth gaping open. Now, this is a symposium about aging and dying. And one of the things about when you're dead is how you are treated. In some ways, in that you're dead, it doesn't matter how you're treated. But it does matter to those around you. And it will influence what they do in the future. Now, I have not been in any other hospital in those circumstances. But Queen Mary is the leading, or one of the two teaching hospitals in Hong Kong. And I think the circumstances where if a service of whatever kind is to be conducted, it should be in better facilities, better surroundings than it was. And I also think the standard, if Queen Mary's mortuary care is as good as you get in Hong Kong, then from the indicativeness of the open mouth, it's not very high. Sorry, Philip.
No. Well, one, I don't know what happened there, but I think two things. Funeral arrangements, be it at Queen Mary Hospital, it's not a Queen Mary Hospital staff initiated or even involved thing. I don't know who was involved in handling the funeral arrangements.
Maybe I'm not making myself plain.
Yeah.
I'm making 2 points. One, the surroundings where the funeral took place. Nothing to do with the staff of Queen Mary. They weren't involved. My point about the staff of Queen Mary, which is the second point, is that the mortuary staff could not even be bothered or were not capable, to put it more neutrally, of shutting the man's mouth. And it distressed people there, including his 14-year-old grandson. And I don't think it's a good standard to put forward.
No, I don't know what happened there again. And honestly, if you ask me personally, I'm disappointed that since you know I'm at Queen Mary and you didn't call me, I could have at least looked at what happened, all right? Again, with regards to the room, I really cannot tell you or say to you anything more than that's all we've got. Most families don't hold their funerals in those rooms, but where they do, it's more for convenience. It wasn't built, and hopefully with the new mortuary, we get a better funeral room. But if you think Queen Mary is bad, you got a lot of things coming if you visit some of the other hospitals. But that's not an excuse. I take your point totally. Overall, I mean, never mind about just Queen Mary Hospital room. I'm not convinced a lot of the funeral facilities around the city, be it the private ones, are necessarily much better if you actually do get to go and look at those. But point taken, it should not have happened. I don't know why you can't close the mouth of a patient. I can, but so that's something we need to look at. And that's all I can say. I don't know why it happened. Yes. Yes.
Hi, similar to this morning, I'm actually very grateful to the Center of Medical Ethics and Law, and particularly Anthony just left. He funded this research center, but seeing so many people persisting and so attentive, I really hope that this is a rare opportunity where the teams of both of the medical universities and Prince of Wales and Queen Mary Hospital comes together. I would hope that there can be systematic follow-up on policy change and guidelines and collaborations, and because each and every scene, each and every sentence were buried in our hearts for so long, especially when it's traumatic. It becomes a post-traumatic stress that we carry throughout our life. So there has been insufficient attention paying on holistic care from end-of-life situations until death and bereavement, funeral services, and etc. So I think it certainly needs a platform like today, with all of your expertise and contributions, to be working towards collaborative policy change, which would hopefully reduce our restraints and enhance our dignity, as well as minimizing, reducing bureaucracies and trying to make things work better and more effectively, so that we won't, in 5 or 10 years' time, sitting in this room and say, we have been talking about this 5 or 10 years ago. So thank you for the organizers and the speakers for this excellent opportunity. Very grateful.
Okay, thank you. Now, can I invite Professor Elsie Chan to say a few words to help close this? And then I'd like to invite everyone to stay for coffee and continue the dialogue. Thank you.
Thank you very much. I'm very mindful we're running over time, so I'll just say a few minutes. I'd like to follow up from Cecilia that this is really I think a groundbreaking workshop or conference. People from different disciplines, all here. There's a book called The Final Exams, How to Take the Final Exams, which is how to die, how to have a good death, and how to live a good end of life. A lot of, I think, words were said about humanism, humanistic, humane. So I would like to say that besides the Center for Medical Ethics and Law, there's a Center for the Humanities and Medicine. And in fact, today's symposium should be a symposium on supporting patient autonomy and fostering humanistic care in old age and death. Now, we can't turn the clock back in the sense that science must proceed, technology has to develop, doctors have to learn more, do more. The law is on our backs. Ethics is very good. It clarifies our thinking as to what is right or wrong. But along the rush, and you and I know, we've forgotten that patient is but a label. What is really happening is that we are helping a person with an illness, old age, or confronting death live the best way he or she can. And I like Amy's point is the end-of-life care involves the person's spiritual, cultural beliefs. Our curriculum is not geared for that. Our curriculum is very downstream, doing task checking lists. We need to come back to the time when I was a medical student, and it's wonderful. I remember the consultants say, as a medical student, you have a lot of time with your patients. Know them as a person. And up till now, my best memories of my patients in medical practice are those I remember as real people. They tell me their narratives. I understand them. They understood me. It's about team care. It's about healing. So again, terms which came up, giving patient hope, trust, love, care, compassion, empathy. Where's that in the curriculum? How much do we pay attention to suffering in terms of loss, stigmatization, suffering, denial? Where's that in the curriculum? But I must say there are good promises. There are a lot of promises that have come up from the angels we've heard of, other things being done possible to the geriatricians. Thank you, geriatricians. And also people in social work. I would say a big initiative, a response to our frantic world comes from mindful practice, mindfulness. Mindfulness means being able to stay centered and still in the face of difficulty and suffering. More than that, to turn towards the suffering as opposed to turning away from it. You know, we don't like suffering, but actually we turn towards it and in a way go beyond empathy. Now, empathy means you share the suffering of your patients and you both cry together. That's no good. There's empathy distress, empathy contagion. The neuroscience of meditation and cultivation, spirituality, says that if you bring in compassion, which is empathy in practice with relieving that, many good things happen, not just to the person you do it to, but to the doer. So I think there's a lot of hope in the way that our human being, our human civilization responding to the crisis. And I think I could go on, but I think tea is waiting. I heard this mindful bell within me. So thank you all. Thank you very much for today. And I look forward to seeing everybody again. Thank you.
Just a quick statement. There's some questions about whether some of the material will be posted online. We will strive to do that, but there have been some requests to sanitize some of the pictures, etc. We'll do that and have them posted. Thank you. Thank you all for coming, but please do stay behind and have a coffee and chat with whoever you would like to.